On to the home stretch. We've been discussing antifungals along the way, but for this last video, we're going to do a comprehensive review. Here's a list of the drugs we'll be discussing. We'll be returning to this diagram of the fungal cell to help us keep track of all the mechanisms of the antifungal agents. Since fungi are eukaryotic cells with similar organelles to human cells, the antifungals will target the major differences between the two cell types. First of all, it is ergosterol, not cholesterol, that is the major sterol in the fungal cell membrane. Second of all, there is a unique makeup of fungal cell walls. At the turn of the 20th century, disseminated and even primary pulmonary fungal infections were almost uniformly fatal. Then, in the 1950s, a drug was isolated from Streptomyces bacteria. This drug class, called the polyenes, revolutionized the treatment of fungal infections. Amphotericin B remains the broadest spectrum agent. This drug is made up of 7 conjugated double bonds and a macrolide ring. The ampho part of the name amphotericin comes from the fact that this drug is amphoteric and amphophilic. Amphotericin B's antifungal activity depends on its binding to ergosterol in the cell membrane, forming cylindrical pores or channels that allow cations and other small molecules to leak out of the cell. This depolarizes the cell membrane, resulting in cell death. Amphotericin is not absorbable from the GI tract. It remains largely protein-bound in plasma. Because it is not eliminated renally nor hepatically, azotemia or liver failure do not alter plasma concentrations or dosing. The major downside of amphotericin B remains its serious side effects. We can think of these in 2 categories. The first category are infusion reactions. This cytokine-mediated phenomenon is experienced by most patients in the form of fevers, chills, rigors, nausea, or vomiting. These infusion-related side effects may be lessened by slowing infusion time or with prophylactic treatment. The other major side effects can be thought of as acute to chronic. Amphotericin B is extremely nephrotoxic, resulting in acute kidney injury from direct renal tubular toxicity. This also results in electrolyte disturbances. This nephrotoxicity takes weeks to months to recover. It can be lessened with sodium supplementation. Another acute to chronic side effect is a normocytic anemia. The older conventional deoxycholate amphotericin B formulations from the 1950s has been by and large replaced by newer but much more expensive lipid formulations. The 3 different lipid formulations available each allow for larger doses to be given with significantly reduced infusion-related side effects and less long-term nephrotoxicity. With its broad-spectrum activity, amphotericin B may be used in resistant, severe, or disseminated superficial infections, endemic fungal infections, or opportunistic fungal infections. Inducible resistance is very rare, but a very few species have inherent resistance. Nystatin is also a polyene. It is used as a swish and swallow treatment for mucocutaneous infections of the GI tract. Since polyenes are not absorbed through the GI tract, the nystatin remains in the lumen and there are few systemic side effects, though the taste is notably awful. The next group of antifungals we'll be discussing are the azoles. The azoles are available in oral, IV, or topical formulations. While they have several mechanisms of antifungal action, the most important is inhibition of 14-alpha sterol demethylase in the ergosterol synthesis pathway. The spectrums of the various azoles vary from agent to agent, but all do a very good job of covering candida. Many of the early first-generation azoles are now available in over-the-counter to treat dermatophytosis. You likely recognize many of these names. Azoles interfere with the elimination, half-life, and plasma concentrations of many other drugs. A clinician must carefully review all medications being taken by a patient prior to prescribing an oral azole. Older first-generation azoles like ketoconazole also suppress the corticosteroid axis through non-specific inhibition of sterol production. The other class side effect is a usually reversible hepatotoxicity. Resistance patterns are drug-specific, but inducible resistance is rare. The first azole we will discuss is fluconazole. This extremely important drug has excellent penetration of ocular fluid and CSF. It has excellent oral bioavailability. It has the class side effect of hepatotoxicity and the somewhat unique side effects of alopecia and dry mouth. It is an excellent broad-spectrum empiric agent, particularly in suspected candidiasis. Due to its excellent CNS penetration, it's also a preferred agent for cryptococcal or coccidioidomycoccal meningitis in non-critically ill patients. It is also used in many centers as candidal prophylaxis. But, as you can see, there are many species against which it is not active. Unlike fluconazole, itraconazole has poor CNS penetration and variable bioavailability. But it reaches very high concentrations in adipose and keratinized tissues. Its side effects are similar to fluconazole, but it has a broader spectrum of action. It is the treatment of choice for non-severe endemic fungal infections, for sporotrichosis, or for severe or refractory superficial fungal infections. Compared to fluconazole, it has increased activity against Aspergillus species. Voriconazole is a potent cytochrome P450 inhibitor that has a broader spectrum of action than fluconazole or itraconazole, but that comes at a price. Its side effects are similar to other azoles, but a unique side effect of voriconazole are visual disturbances and hallucinations. This drug is metabolized by CYP2C19. And there are genetic polymorphisms in this cytochrome, which can cause four-fold differences in drug metabolism. Tests can be ordered to screen for the slow metabolizers. It is active against all species of Candida, but more importantly, it is very active against Aspergillus species. In a trial in 2002, voriconazole was shown to provide superior efficacy to amphotericin B for treating invasive aspergillosis. This is the most important use of the drug to remember. Posaconazole. This derivative of itraconazole is similar to voriconazole. One difference is that posaconazole is only available in oral formulations and must be administered with food to ensure bioavailability. For our purposes, it has a few notable uses. It is proven superior in candidal prophylaxis, while also prophylaxing for Aspergillus species. It is sometimes used in refractory candidiasis, and less importantly, it is a possible second-line choice in the treatment of mucormycosis. Its side effect profile is similar to other agents, with the additional unique side effect of QT prolongation. When discovered in the 1970s, echinocandins added considerably to the antifungal armamentarium. They have poor oral bioavailability. There are 3 available agents, and they have the same mechanism of action, similar side effect profiles, and may be thought of interchangeably. Recall that the mechanism of action is direct inhibition of 1,3-beta-D-glucan synthase. By inhibiting glucan linking, the structural integrity of the fungal cell wall is reduced, resulting in fungal cell death. They are also fungistatic against Aspergillus. Echinocandins are remarkably well tolerated. Their main side effect is minor drug-to-drug interactions. There is also occasionally a histamine-related infusion reaction. Their main use is in treating candidiasis. These drugs have performed non-inferiorly for treating esophageal and invasive candidiasis. Candida parapsilosis is resistant to echinocandins in vitro, but again, the clinical significance of this finding is unclear. They also have good activity against Aspergillus, though inferior to voriconazole. Flucytosine, the precursor to 5-fluorouracil, is a chemotherapeutic agent that interferes with DNA synthesis. It has predictably severe toxicity. Because it has excellent penetration of the CNS, It is used in combination with amphotericin B for treating cryptococcal meningitis. Dual therapy has been shown to improve mortality when compared with using amphotericin B alone. Flucytosine is never used as a single agent as rapid resistance occurs. In the class of allylamines, we'll be discussing terbinafine. Terbinafine is available in oral or topical formulations. This agent inhibits squalene epoxidase in the ergosterol synthesis pathway. Due to its propensity to build up in the skin and nails, it is used for treating dermatophytosis and onychomycosis. It's well tolerated, with side effects including diarrhea and temporary taste disturbances. It's available in topical form over the counter. Well, that's it for antifungal treatments and fungal infections. Good luck studying. Here is a list of first-line treatments. See you in class.